Assalamu alaikum. Today we'll discuss catheter-related bloodstream infection. We'll talk about the outline definition of the catheter-related bloodstream infection, what are the standard diagnostic techniques, and how to prevent the catheter-related bloodstream infection, and how to identify the antimicrobial strategy. To the intensive care after RTA. Trauma survey revealed brain contusion with right femur fracture. Upon admission, central was including pain. 7 days later, after ICU admission, the patient started to develop fever and chills. Vital sign revealed heart rate 110 beats per minute, blood pressure 120/60, respiratory rate 28 per minute. SpO2 was normal, temperature was 38.5 degrees centigrade, TLC was 14,000, and chest X-ray was clear, but the exit site showed erythema and purulent discharge. Case 2, 35 years old male, all female patient admitted to the intensive care after major abdominal surgery. The right internal jugular vein was inserted in the operating room, so it's completely under aseptic condition for sure. The total parenteral nutrition was started, and 10 days later, after ICU admission, the patient started to develop fever, chills, and hemodynamic instability. Vital signs showed the heart rate. The patient was tachycardic and hypotensive. Respiratory rate was 28. Saturation was SpO2 was normal. Temperature was 39 and TLC was 20,000. Norepinephrine was started. Chest X-ray was clear. The abdomen was lax and ultrasound was negative for collection. And sertraline exit site was clean as seen in the figure. Case 3, 75 years old female patient admitted to the ICU with disturbed consciousness. MRI was done and revealed right occipital mass. Upon admission, peripheral line was inserted in the left antecubital vein, and 4 days later, the patient started to develop fever and tachycardia. This is a sign of thrombophlebitis in the cannulated vein. The vital sign showed the patient was tachycardic, normotensive. Respiratory rate was 20, SpO2 was normal, temperature was 38, and TLC was 11,000. Chest X-ray was clear, but the blood culture was done twice and revealed coagulase negative staph. So, how we can differentiate between the catheter-related bloodstream infection and central line associated bloodstream infection? The main difference between both are the catheter-related bloodstream infection. We are sure that the intravenous catheter is a source of bloodstream infection. Positive blood culture with the same organisms from the isolated from both the IV line and also bloodstream. So the catheter-related bloodstream require microbiological data to confirm that it's from the catheter. While in catheter central line associated bloodstream infection, in patient with bloodstream infection, patient with central line in situ for more than 48 hours, but there is no other evident cause of evident reason or sources of infection, and the definition is used for surveillance. So the definition does not require for CLABSI, does not require microbiological data. So when should we suspect that a patient had catheter-related bloodstream infection? First, if it is a sign of local sign of infection, as in case 1, there is an evident local sign of infection, or the IV catheter and there is an IV catheter and the patient is feverish, there is no other source in the absence of local sign of infection at the site of catheterization. Or intravenous, patient has an intravenous catheter and there is a metastatic infection, infective endocarditis, joint infection, lung abscess, and there is no other reason that can clarify why there is systemic symptoms of infection. or the persistent or recurrent infection caused by organisms, and these organisms colonize on the skin like coagulase negative staph. We repeated the culture and we find that this organism we found in every culture center from the patients. Okay, so in case one, there is local sign of infection, as we said before. Case two, the IV caster and there is fever and there is no other source. Definitely, there is no other cause for infection. Two, and in last two cases, case three, there is persistent or recurrent infection caused by organisms that colonize on the skin. We send the culture and we found that there is coagulase negative step and there is a sign of infection from the inserted intravenous catheter. So we have to suspect there is CREPSI, which is catheter-related bloodstream infection. Okay, how to confirm our diagnosis? To confirm your diagnosis without catheter removal or with catheter removal. Okay, if without catheter removal, we should have per quantitative blood culture. So we take blood culture from the central line or from the catheter and from the peripheral blood. And if we found that the colony counts in the central sample of blood taken from the central line more than 3 to 1 more than the peripheral, the colony counts, so we are sure that the infection is from the catheter. Or we take paired blood culture with different time of positivity. Both sets are positive for the same organisms. So we take blood culture, a culture from the central line or from the infected catheter, and we take a culture from the central peripheral blood. If the central blood culture sent from the catheter become positive for or gross the organism, the lab informed us that the organism we have a positive organism after after 2 hours different between both culture. So we confirm that the culture, the source of infection is from the catheter. Okay, if there's 2 hours difference between two sets and the early growth was from the catheter. Okay, there's growth from both the paired culture, but the growth was earlier in the central catheter. Blood sample taken from the culture taken from the central catheter or the peripheral catheter. Superficial culture from the skin plus peripheral blood culture, and we found that the semi-quantitative culture of the skin surrounding the portal artery portal entry account for more than 15 colony forming units. Positive peripheral blood culture for the same organism. So we take culture from the around the inlets or exit of the catheter, and we found that it's the same organism was found in the peripheral culture with a high colony count in the culture taken from the scan. Okay, so to diagnose a CREPSI with catheter removal, it's very simple. So we have the catheter, semi-quantitative catheter culture, the semi-quantitative catheter tip, take the tip of the culture. If it's more than 15 colony forming units, positive peripheral blood culture for the same organism, so we have to confirm the diagnosis. Or quantitative catheter culture, if we have the catheter tip, catheter culture, colony forming to more than 10 to the power of 3, so there's positive peripheral blood culture for the same. And we know the difference between semi-quantitative and the quantitative. The quantitative, we have a confirmed colony forming units by the MIC, and the semi-quantitative, it is a mild or intermediate or heavy growth of bacteria. How to choose a diagnostic technique according to the patient condition. If the patient have a suspected CREPSI and they have a high risk of complication, to remove the catheter, like patient hemodynamically unstable, neutropenic less than 5,000, have patient with organ transplants, Patient has an intravascular device, pacemaker, precious device, prosthetic valve, or patient has separation or induration around the site of the catheter. So we have to change this catheter. Should we remove the catheter? But before we remove the catheter, we have to insert another one, and we will know how to insert the other one either by we have to use the ultrasound or not. Or single different puncture, we have to use a single puncture and ultrasound guided to decrease the risk of complication. So in high risk patients, if high risk patient, yes, he is a high risk patient, so we have to remove the catheter tip and ask for peripheral blood culture also. If the culture is negative, we consider alternative diagnosis. If the culture is positive, we have to adapt the antibiotic according to the culture. If there is no risk of complication, so we can go um, we have differential time positivity or quantitative blood culture is available. If it's not available, we have to remove the catheter. But if it's available, we can wait. Catheter maintained in place and we initiate empiric therapy. If the culture is negative, we consider alternative diagnosis and we should not remove the catheter. If the catheter is culture is positive, we can continue for antimicrobial if the patient have no risk factor to urgently remove the catheter, as we said. So, in patient number one, case number one, there is local sign of infection and the patient has a local sign of infection. The patient number two have a hemodynamic instability, and patient number three we have local redness. So we send for culture tip, peripheral culture, and we remove the catheter if possible. Especially we have to remove the catheter in case two if the patient has hemodynamic instability. So how to replace the catheter? The best is to do a new puncture, sorry. New puncture, new vein puncture should be the default practice in catheter replacement. The catheter should be inserted with ultrasound to decrease the risk of a mechanical complication. If we exchange the over guides, never to do it if the catheter sign of infection or suspected CRAPSI. So the guide wire exchange is restricted in difficult cases like burn, obese, or severe coagulopathy without infection, documented infection. And if the catheter tip is positive, the new line inserted over the guideline should be replaced by a new direct puncture. So, how to choose the empirical antimicrobial therapy for those patients? We have to think about what is the commonest organism on the scan. The commonest organism is the gram-positive cocci, like methicillin sensitive or methicillin resistant staph aureus, which is more common in our country. Um, Gram-negative bacilli like Pseudomonas, Klebsiella, and Acinetobacter, also Candida species, which is common in patient with organ transplant patient with a patient with TPN or femoral catheter, venous catheter. We have to select the antimicrobial according to suspicious organism. But if the patient has a suspected CRAPSI, to start, we have to all patients should receive empiric coverage for gram positive, which antimicrobial vancomycin is the first line for empiric therapy. When we could shift to daptomycin in patient with as indicated if the patient with CRAPSI and septic shock, patient has acute kidney injury, and patient have previous exposure to vancomycin for more than a week. Linezolid is used only in patients contraindicated to the daptomycin or vancomycin. Teicoplanin is not recommended as empiric therapy, except it is the only available for those patients. And we have to use the maximum dose of teicoplanin for every 12 hours for first 5 days, and we continue our treatment regimen for teicoplanin. Gram-negative Gram-negative bacteria coverage is indicated in neutropenic patients, patient with organ transplant, patient with a femoral catheter, patient has high index of colonization of gram-negative bacteria, and patient with prolonged ICU admission is mandatory. How to start, what to start for those patients? As we all know that cefepime, piperacillin, tazobactam, and sterinum should not be used in patient with extended spectrum beta lactamase resistant uh, organism. So we have to give meropenem plus fluoroquinolones or aminoglycosides. The patient, if we suspect candida or high risk of candida, and patient with total parental, as I said before, total parental nutrition, patient has a femoral catheter, patient having candida colonization at multiple sites. So echinocandine are indicated as a first line of treatment, especially in hemodynamically unstable patients. If there is previous exposure within the previous 2 weeks for azoles, high incidence of candida non-albicans. If there is a high incidence of candida non-albicans. So in case number one, we should give vancomycin plus meropenem because the patient has a prolonged ICU stay. The second patient, we should start vancomycin, meropenem plus the fluoroquinolones or aminoglycosides, echinocandine because the patient is hemodynamically unstable and TPN was started. And case number three, we give only vancomycin. So case number one, blood culture, post culture from the Catheter tip and blood revealed MRSA sensitive to vancomycin. But after 72 hours, the patient still feverish, blood culture was repeated after 72 hours, and there's still positive for MRSA. For those patients, what are the cause of persistent bacteremia? There is infection elsewhere. Persistent bacteremia or fungemia, more than 72 hours despite adequate treatments. The persistent might be due to metastatic foci of infection like infective endocarditis, lung abscess, or anywhere in the body. There is suppurative thrombophlebitis and local thrombosis in the vein around the infected catheter. And in these patients, the ultrasound, the Doppler ultrasound, vascular ultrasound revealed thrombus in the right internal jugular. So we should manage this patient as a patient with infective endocarditis. For how long we give the antibiotic is a very important issue to be um, kept in mind during management of patient with bloodstream infection. We um, we have a targeted antimicrobial therapy. If there's complicated infection, patient persistent fever more than or bacteremia more than 72 hours, there is a suppurative thrombophlebitis, there is septic metastatic infection, our patients immunocompromised patients. So we have to continue the treatment for 4 to 6 weeks. In patient uncomplicated, if the patient have a gram-positive cocci, Coagulase negative staph only for 7 days, enterococci for 7 to 14 days, but if it's staph aureus, we should continue for 14 days because it is a very sticky organism to the valve, to the joints. So it's very sticky organism, staph aureus, so you should continue our treatment for 14 days. In gram-negative bacilli, or continue either 7 to 14 days according to the patient condition, according to the decreasing of the inflammatory markers, according to the hemodynamics of the patients, and accordingly we discontinue the antimicrobial. While in candida species, please keep in mind if the patient has a candidemia, we should continue for the antifungal treatments for 14 days after the last negative culture. Okay, so some patients need an echocardiography. The most important of those patients are the patient with complicated infection to exclude infective endocarditis, patient with enterococci, and we said patient with staph aureus, and patient with candidemia. So, how can we prevent CRAPSI? It's a very important issue. Prevention, keep in mind, please, that prevention is important than cure. Okay, to prevent the complications or the occurrence of CRAPSI, we should think many times before insertion of the peripheral central venous access. If the peripheral venous access is inadequate and the patient is hemodynamically unstable and septic manifestations, or we have an infusion difficulties, so we should go for central line access. If there is no risk for to continue with peripheral IV access, we can go for peripheral access under complete aseptic condition. We can keep the peripheral access from 1 to 4 days, according to the patient condition. If there is no sign of inflammation, once there is sign of infection, remove the catheter. If the patient transferred to the ICU from the any from the OR or from the from the emergency departments, we have to remove the catheter within 24 hours and insert another one and keep it for maximum 27 to 96 hours. The if we have to insert peripheral access, and either we insert central line tunnels, if we can use the tunnel central line, it's better to be used if the patient had a prolonged ICU stay and there is recurrent infection from the central line. So use the tunneled central venous catheter, or use what's called uh, uh, peak is the peripherally inserted central catheter. This catheter could be remain inside. It's inserted either in the cephalic vein, tracheal vein, or basilic vein. Its length extended from 38 to around 52 centimeter. It can extend to the internal jugular vein, and it can be kept for a few months. Or a midline caster also inserted in the brachial, cephalic, or basilic vein. Its length from extended from 8 to 12 centimeter, and this could be kept up to 1 month. Also, we should keep in mind the complete sterilization before insertion of the catheter. Um, use chlorhexidine 2%. It's very important to be done before catheterization, central venous catheterization of the patients. Thank you.